University. This is Office Hours at Duke University. Today, Professor Peter Ubel takes your questions about making medical decisions. Ubel is the Jack O. Blackburn Professor of Marketing at Duke's Fuqua School of Business. He is also a professor of public policy at the Sanford School and a physician. His most recent book is Free Market Madness: Why Human Nature is at Odds with Economics and Why It Matters. To ask Ubel a question, send an email to live@duke.edu. Tweet with the tag DukeLive or post to the Duke University Facebook page. You can watch today's discussion again anytime on Duke On Demand.
Greetings. Welcome to Office Hours at Duke University. I'm Carl Bates from the Duke News Office. We're here today with Peter Ubel, MD, who happens to teach on the faculties of the Business School and the School of Public Policy, the Fuqua School of Business and the Sanford School of Public Policy. So the obvious question is, how did a doctor end up doing these things?
There aren't a bunch of doctors doing this. I have, I think, a genetic predisposition to not specializing in anything. I didn't know what to major in college. I didn't know what to specialize in medical school. And now I do research that's so interdisciplinary, it's probably completely undisciplined. And so partly I'm someone who likes to find overlap in areas. And the questions I was finding as a doctor that I wanted to answer, I knew I couldn't answer with medical tools. I needed social science tools.
So you were a practicing internist, seeing patients at the VA. And when did you start to think about these larger policy and behavior questions that you now work on?
Actually, during my clinical training, I was at the Mayo Clinic in residency, becoming a general internist, and I was asked to see a patient who had just had his 4th liver transplant, and I was there to help decide if he was going to survive this transplant or not. He ended up dying, and I remember at that time thinking, how did he end up with 4 livers when some people are waiting for their first and might die before they get it? And I realized, I can't just sit here and do clinical medicine and not answer these bigger questions or try to be part of the solution to these bigger problems.
And what was the answer? Why did this one patient get 4 and somebody else didn't? Was it a matter of means? Was it his insurance?
No. You certainly need insurance to get on the list. That helps. But once you're on the list, once you've been transplanted and you need another liver, you tend to get sicker, which moves you up the list. You tend to have surgeons who are very committed to your well-being because they know you well. They don't know the people on the list. They're taken care of by gastroenterologists. Plus, their statistics of their outcomes depend on post-transplant survival, not survival of the people waiting. So the whole system is skewed.
The system, right. you started, I'm not sure at what point, but you started developing this idea that became that first book that you did, Pricing Life, and it's a critique of the free market system's shortcomings when it comes to providing healthcare, which is something different from providing breakfast cereal or automobiles. But we run it on the same kind of system.
Except in medicine, of course, when you can't afford it, you might die. And so if I can't buy a new car, I'll get by.
Yeah.
But if I can't afford that liver transplant, or if I can't afford primary care that might keep me from getting a heart attack, you could die.
But people very often will argue, without our free enterprise system, General Electric wouldn't have the incentive to create the next generation MRI. We wouldn't have these wonderful diagnostic machines that we've got. We wouldn't have these great drugs that we've got. It's free enterprise that drives innovation and makes our healthcare, arguably, they say, the best in the world.
Yeah, it's not the best in the world. I mean, by some measures maybe, but not by most. But you look at the reason that we have all the MRIs we have, it's actually because of Medicare. Because when Medicare was established, it paid well. And that's when doctor salaries went up. That's when you knew that when you ordered something on a patient, it would get reimbursed. So it's not just completely a free market system.
But Medicare is the government. It's not free enterprise.
Exactly. That's my point. But once it says it's going to pay something for some service, the free enterprise system will interact with the government and know that it can bill the government. So it's not a completely clean system either way. But
so a question already from online. Who is the best in the world in healthcare? It's the United States, right? That's what I've heard in Congress.
That's, of course, there's no one definition of best.
Okay.
But if you look at access to care, we're way down at the bottom. If you look at affordability of care, we're behind every other industrialized country. Even if you look, though, at like surgical outcomes, we often are in the middle of the pack. And there are some things we do very well. We tend to give people blood pressure pills when they need them and mammograms when they need them. But there are all kinds of things. We make more hospital errors than a lot of systems that have electronic medical records and better quality control systems.
Mm-hmm. So how do we get from where we are now to this utopian electronic medical records? I don't want to say rationed because I know that's a bad word, but how do we get from where we are to where we ought to be, in your opinion?
Well, there is no utopia. Every industrialized country in the world is unhappy with its medical system. Some of them are less unhappy than we are, but they're all trying to control costs. No one has a way of figuring out how to do that. And they're all struggling to give people access to good quality care.
Aren't we paying twice as much as the single-payer nations?
Well, we're paying twice as much as nations with private health insurance that's quite robust too. So it's not just about whether it's single payer.
Yeah.
We just pay a lot here.
Yeah.
And it really did start with Medicare.
That's interesting. So our government program, which seemed like a good idea at the time, is actually what's driven us over.
Well, it is a great idea for lots of things. It wasn't a great idea for controlling costs. The AMA opposed Medicare before it came out, but the doctors benefited more than anybody because they said, we're going to pay 75% of the standard rate in your area. So that meant already, 3/4 of doctors could raise their fees.
So is Obamacare the solution, or is it merely a step in the right direction?
It's a step, and what direction it's going to be, who knows?
All right.
They really have a lot of improvements to give people access to care. When it comes to controlling costs, there's a lot of to-be-determined laters.
So you just told me a couple minutes ago that you're teaching an undergraduate course this term on Obamacare. I'm not sure I even like that name for it, but people know what it is.
Yep.
And what is that course about? You're dissecting what was in that plan and talking about what's good and bad about it, or?
We started off showing the students where the U.S. ranks on cost, quality, and access to care, asking them and saying, this is what Obama inherited, and felt that all three of these things needed to be improved. And we first said, what would you do if you could only tackle one of these? And they all went after what they thought was the most important and said how easy it would be to solve. And now they're in the process of being completely bewildered and realizing that none of the three things are easy.
Yeah. Add to that discussion lots of moneyed interests trying to drive their particular agenda, and it gets to be pretty tough to be a congressperson in that situation.
It'd be hugely tough, yeah.
Yeah. That explains how we got into the mess we're in at the moment. Here's a question from email. Could Peter give us a quick and dirty overview of Obamacare? And what is the topic the students most wanted to solve? What did they pick on right away that they thought was a problem?
Yeah, well, I'll take the second question first. They thought either access or cost.
Yeah.
And a lot of them thought cost was most important because if you reduce the cost,
Then
it's
you get more
easier to
access.
improve. Exactly. Right. And I actually think that is the most important thing. So maybe they just read my own bias and they were trying to please me. But then the quick overview of Obamacare, the problem is there is no quick overview.
Yeah.
And one of the things the students are learning is just how complicated the system is. We had a session on the public option, and you saw all these people who came in with very strong opinions about the public option, and the more they learned about it, the more they realized, wow, it's not so straightforward. We don't know what would have happened if there had been a public option.
Yeah.
Would it have driven private insurers out of the business or not? Or would it have just relieved them of the sickest patients? No one knows.
So the compromise solution is, okay, we're going to compel more people to join healthcare plans, and now the court fight is about, well, you can't force people to buy a product.
Yeah.
But it's not a regular product, it's insurance, right? The more people that buy it, the cheaper it gets. It's,
And the more we can average costs across people.
Yeah.
And the more people can't just wait until they're sick to buy it.
Yeah. Healthcare is apart from other kinds of economies.
Yeah, it is.
It's really different.
Plus, we're actually legally required to take care of people when they're emergently ill. So whether you have insurance or
Right.
not, you have to get cared for.
Yeah.
So-
The emergency room is what really drives a lot of our Medicare.
It does. And so if we're
difficulties, right?
requiring emergency rooms to offer care, it makes sense to require people to have insurance.
Well, you're a licensed physician. How can you not treat somebody when they come to your emergency room in dire straits? I mean,
You can't morally...
compensation aside, you have
right.
to deal with that problem.
Absolutely.
Yeah. We've had a question about compensation as well in regards to electronic medical records and the increasing amount of time that physicians seem to spend dealing with their patients via email, if they're open to that and all of that. It doesn't seem there's a good system for compensating physicians yet for that amount of time, the time they spend staring at a computer.
Right.
Because they're paid usually by patient contacts, how many patients they can get through the mill in a day.
And one of the things that's in the health reform legislation are pilot studies to try different ways of paying doctors. Maybe you just give them a pool of money to care for a pool of patients, and then they figure out how to spend their time doing that, what the most efficient way is. But they've got the money up advance. It's more like going to a salaried model of physician care rather than charge for every service.
So a lot of attention was drawn to the Mayo Clinic about their
Yeah.
salary system. How do you feel about that?
And that's where I trained. It's a great place.
But their physicians are on salary. They're
Yeah.
not driven for high throughput, lots of patient contact. They're just allowed to sort of do their jobs.
Well, but they're also watched closely how many patients you see and how much revenue you generate. So it's not completely
They do have to be
simple.
productive. Okay.
Absolutely. Yep.
And what's the feedback from those doctors? Are they happy they're in that position?
I guess if you're self-selecting people who will live in Rochester, Minnesota, where it's still about 10 degrees right now,
Yeah.
And I grew up in Minnesota, I love the state. It's a great group of people who are very happy. They've understood the system, they've grown up in the system, and they see its benefits.
Yeah.
It's hard necessarily, though, to impose that system on other people, right?
I guess. I mean, it works because Mayo has that distinct identity and yes, remoteness from other markets. If you're a physician in that part of Minnesota,
and when people take a job there, they know what they're getting into.
Yeah.
Just like when I worked at the VA, I knew I was going to be salaried
Yeah.
and that I was going to have different kind of surroundings.
So in a market like New York City, you wouldn't expect one of the healthcare centers to go to this while their competitors are not.
I just don't think you can impose from the top and say every doctor has to go into this kind of system now. There'd be
Yeah.
a revolt.
Yeah. Where does reform come from? If it's too complicated for Congress, if the market has fallen flat on it, if you can't impose top-down solutions, how are we going to get out of this?
Oh, you want a simple answer, right? Yeah, I thought you said you wanted every answer short. No. So I think what the Obama legislation is trying to do is set up incentives to change models of care and then assess which models work best and then build up more incentives for those kind of models. And then let the system kind of organically or almost in a free market way adapt to the new payment schemes. So it's not a bad idea, but it's going to take a long time.
That much is clear. And a lot has been said for the supporters of what the Obama reforms attempted that, okay, this isn't the final solution, but it's getting us towards what we need to do.
Yeah, and we try to avoid phrases like final solution when we've
My
been talking
apologies.
about death panels. And
Yeah, so the rhetoric gets in the way, too.
Yeah.
Somebody can get off a quick phrase like death panel, which actually didn't exist anywhere in the legislation, but that meme just grabs hold.
Yeah.
And the 24/7 news people repeat it, and suddenly it's true.
People are afraid of change. And so the more you kind of remind them of change and then put scary ideas out there, those scary ideas become believable because they know they're afraid of something.
Yeah. Which brings us to your latest frontier. You're actually exploring the ways in which the human psyche makes bizarre choices, or what our Dan Ariely calls irrational economics, that we think we understand how consumers make their choices, in your case, healthcare consumers, but there's so many ways to tweak that and to derail that. How are you exploring that at present?
Well, we're doing a lot of research where we're looking at how people make decisions, patients make decisions when they're faced with trade-offs. There's no right or wrong choice, and they have to take all this complicated information and decide what to do with it. And we look at what goes wrong. We look at how if I present the information this way rather than that way, you get a very different choice. And how the doctor raises his eyebrow this way versus that way, and again, it can totally influence.
So give me an example of the choices. I'm presented with two different risk scenarios. How can you skew my choice by how you present it?
Well, you can discuss. Take prostate cancer. You can.
Okay.
One of the options for people with localized early-stage prostate cancer is watchful waiting.
Mm-hmm.
And people think watching. That sounds like you're not doing anything. So they've renamed it active surveillance. And little things like this, framing those treatments, the same approach in different words, feels very different to people.
Active surveillance means I'm doing something, whereas
Yes.
watchful waiting means I'm sitting on my hands.
Absolutely.
And since you've already said the C word, I feel like I have a ticking time bomb.
Absolutely, and that's exactly the metaphor I use. But people feel like it's something they have to do something about. They have to be active in getting it out of their bodies.
Huh. Clever.
Even though the active treatments have a lot of side effects.
So now, how do you get all the urologists in the country to change that
Oh,
phraseology?
they've been using active surveillance more, although they also have an incentive to do more operations. So,
Yeah. With mixed results. Now, I heard you present a few weeks ago at a brown bag symposium, and you were talking about a video study that you're doing of doctor-patient interactions. Tell us a little bit about that.
well, we've actually been taping interactions between doctors and patients when the doctor's giving a man news that he has prostate cancer and then trying to help him decide what to do about that cancer. And what we're finding is really a lot of great effort from the doctors to communicate lots of information to patients who are probably not emotionally in a state of mind to absorb that information. Almost no time, in fact, in the encounter is spent helping them absorb the bad news. And then a decision often made within 15 or 20 minutes of finding out you have cancer.
Wow.
Without seeing another specialist with a different opinion, without going back to your primary care doctor to get a different perspective.
So in the same visit, they're
Yeah.
told the bad news.
Yep.
These options are laid out that they may or may not understand.
Yep.
They don't have any time to soak on it.
Yep.
And then they're supposed to make a choice.
Yep.
How would you fix that?
Yeah, first off, sleep on it. I think
Yep.
there's first off, it's just good to have time, and there's even increasing evidence in the behavioral literature that when you're not thinking about something, you're actually still thinking about it. Your brain is still processing it
Heck yeah.
unconsciously, and that can improve decision making.
Yep.
The other thing is we actually have developed a DVD that we give patients before they have that visit and say, we don't know if you have cancer or not, but if you do, this is what your visit might look like, and here's what you can do to slow things down. And we give them actually, we reenact visits and then show the patients taking different approaches to just get that train a little bit lower.
Yeah. Can you lay out the options for them in advance as well, or is that
Yeah.
too specific?
We can, with it, when we know it's a localized cancer, that we can do that, but there's still always going to be details that the doctor would have to then fill in.
Why have you chosen to use prostate cancer for these studies? I mean, there are lots of conditions you could study that way.
Yep, well, you have to choose one. First is
Right.
the National Cancer Institute, one of the parts of the NIH, is more interested in behavioral science than almost any other branch of the NIH.
Interesting.
So it's great for people with cancer because that means there's behavioral scientists trying to help out.
Yeah.
The other reason is this is really one of those situations where there's no right or wrong decision, and it depends on a patient preference. And so we want to help patients get their voice out there.
So it's interesting to me. You clearly consider yourself a behavioral scientist now, but you're not a psychiatrist. Do you regret picking internal medicine as your
No.
specialty? I mean, had you known where you'd be now?
No, I have no idea. I can't second guess. I've
Yeah.
had a great life, and my job is incredibly fun. No, I'm a generalist. I
Yeah.
like to think about broad things, and general internal medicine has been a great place for me to
Yeah.
see all kinds of aspects of medicine, at least adult medicine. You know.
And how much of a leap was it to get hired into a business school and a policy school at Duke
Yeah.
with no PhD in a related field?
Yeah, well, it is a leap, mainly in the imagination of the school that would have been thinking of hiring me, and that's really to Duke's credit, or maybe their insanity. They saw that I didn't need the PhD after my name. They saw the work I'd done and realized its relevance and its value, and that was really one of the really attractive things about coming here, is that this place values interdisciplinary research and collaboration across the campus. They thought it was exciting to bring me in. I actually have an appointment in the medical school too. So here we are. We're just reaching across different parts of the campus, and Duke values that.
Yeah. So how do you, Peter, affect change? You have some pretty strong ideas. You have a lot of data now building up about what's wrong with the system. Beyond writing books, what can you do? It must be frustrating to you to not be able to have more ability to change this massive, complex system.
You're trying to make me very depressed, aren't you? I mean, so I definitely ask these questions a lot. And
Yeah.
but writing books is one of the ways. And the more you can have books that hit more people, and I'm writing another book right now. And if it has the kind of impact I hope it'll have, that will be it'll strengthen my voice in talking to other people too.
And that book is more about these doctor-patient
Yeah,
interactions. That's
it
where
is.
the prostate study comes
Absolutely. But I think other than that, I think going in and trying to train doctors to think differently, that's one of the reasons I'm excited about training undergrads about health policy. Probably half of the class I've got are pre-meds. I don't think they're going to think about the healthcare system the way the rest of their classmates do, and I think the world
Yeah.
will be better for that.
in. Yeah, they're too focused on getting through organic. It's good that you're
Right.
helping them a little bit
Yeah.
with the other side. Was that your transformation as well? You did all this scientific training, and then you got into the clinic and realized, wow, there's a whole
I was
behavioral
I was
part
a
to
philosophy major as an undergrad,
Ah, okay.
so I already had a little bit of I asked a lot of questions about a lot of things.
Yeah.
And then when I did my clinical training, I was looking a lot at the ethical dilemmas that were going on in healthcare. And I only found behavioral science when I realized that a lot of ethics is really moral psychology. It's people feeling very passionately that something's right or wrong, but I can frame the same situation differently, and now it's okay.
Yeah.
And so,
And have you had any involvement with what's usually called bioethics, which is the individual morality? Do you serve on bioethics panels or any of those kinds of things?
I used to do bioethics consultations. I used to go in the hospital, and then when they got to loggerheads in the hospital about what they thought was an ethical dilemma, I was one of the people that came in and helped solve it. Things like woman was in the operating room, and they realized her tumor was bigger than they thought, and that they'd have to remove her ability to speak, to remove the tumor.
Wow.
And they're already in the middle of a big operation when they realized this. And they paged me emergently and said, do we need to stop the operation and wake her up and ask her, which means we won't be able to do it again for another week and it'll be a second surgery? The answer was yes. You do need to ask her before you take her voice away.
Yeah, I would think. Thank you. So here's another question off the email. What about integrative medicine and health policy? How much does Eastern medicine and the holistic view of the person fit into preventative care, and how could the healthcare system incentivize that kind of thing to save the money up front?
First thing is preventive care doesn't usually save money.
Really?
Yeah, we think that. It's just not, the evidence isn't there. It's good to do for other reasons. It's a good way to spend money. You get sometimes a lot of benefit for a small amount of money, but it costs money. And sometimes you can spend a lot of money. You can spend $1 million and have 1 year of life you gain in pap smear testing if you screen the wrong population. So it's not always cost effective even.
Yeah, well, there's the huge argument over mammography last year.
Yeah. But in terms of integrative medicine and kind of complementary and alternative medicine, I just believe in evidence-based medicine. And so if there's evidence that something works and it's cost effective, we should do it.
Okay, so is that your way of answering the holistic Eastern medicine question?
Well, I'd answer the same thing about half the surgeries we do.
Yeah, that they're not evidence-based.
No, that they need to be evidence-based,
Yeah.
right? And so there is evidence for some treatments that are called complementary and alternative, and if it's strong, it should be just called medicine, medical care.
Gotcha.
Yeah.
So how well does the NIH allocate its resources for that kind of outcome evidence-based stuff? I mean, a lot of what they spend their money on seems to be developing these expensive new treatments.
Yes, I agree. So this is my bias. I think that more of the NIH budget should be going not to molecular biology and genomics, but to behavioral science, to outcome research, to implementation research. And I think it would be a better system. It would change the type of people who are med school faculty, and I think medical schools would be less about teaching people molecular biology, which doesn't make you a better doctor, and it'd be about people teaching about behavior and economics, which does make you a better doctor.
And there you go, trying to change a whole other
That's what
system.
I'd like to. No, yeah. If I was the boss.
Dr. Don Quixote.
Thank you.
I hope you're not tilting a window. So in this latest book, how much of this is about what Dan Ariely calls irrationality, that patients see one thing and think another, the way you can skew that? Is that the gist of what you're trying to explain to people?
That's just part of it.
Yeah.
I think for people to make good decisions, it's nice to be rational. It's nice to be informed. Probably really important is that you and your family talk to the healthcare providers and everyone understands each other.
Yeah.
And so a lot of what I'm really aiming at is better communication, better understanding.
Got it. Related to that, Stuart from the web asks, are consumers doing a good job of processing the flood of health information they have available these days? I mean, Google always says that healthcare terms are one of the leading things that people are searching for by a huge percentage. There's so much information.
Yeah.
Some of it sponsored by drug companies. How do patients sort that out?
I don't know. I mean, how do you teach people to be critical thinkers, right? I think that people are deluged with information. What's tough is that some of it's contradictory.
Yes.
You learn one week that you should have hormone replacement at menopause, and the next week you shouldn't, and then it just keeps going back and forth. And people,
Caffeine's good, caffeine's bad.
Yeah, it's good.
I like it.
Withdrawing from it's bad. So I think people are. I think what you want to do then is try to have a good clinician you can talk to, and you come to them with your explain where you're coming from and what you've learned, and then they can correct you as needed. And so I love
talk
it.
to your doctor.
Sure.
Okay, but part of what I've heard you say about this doctor-patient interaction is the doctors don't communicate very effectively. They're not getting across to people.
Yeah, that's a problem, isn't it? So it's not a great solution, and especially if you talk to your doctor and say, "Yeah, I read about this new pill for restless nose syndrome."
Bring a bunch of stuff from the internet. Here, doc, this is what I found.
And some doctors will say, "Oh, they want a pill," and so if I don't give it to them, they won't be happy, and they'll go find another doctor, and they write the prescription. So I think you really have to be careful in saying, "Doc, I don't come in here. I don't have a strong opinion on what to do.
Yeah.
I just want to know what this means and whether that would be good for me or not." So
I have to wonder if some of this is cultural as well. We've been bombarded now for 2-3 generations with these 15-second ads where there's a problem, ding, here's the miracle. By the end of the 15 seconds, everything's well.
Yep.
And we kind of go to our doctor looking for that, right?
Yeah.
Write me the script, make me better.
Yeah, it's sad if the obesity problem is going to come down to a pill, isn't it?
Yeah,
That's what people are looking for.
absolutely. They're eager for that.
Yep.
Indeed.
Stop watching so much TV, except for places like this.
Stop watching those commercials. Okay, so we're close to the end. I wanted to come back to this idea of your personal transformation. You have learned a lot about human behavior just in the doctor-patient interaction. You've discovered things about the human psyche and a person's most vulnerable kind of transaction, most intimate transaction. I guess I made that statement, not you.
Yeah, was that the question?
And where you hope to go from here is pursuing policy and this idea of decision making.
Yeah, I would love, in the long run, I really would love to transform both medical education to just be able to be a voice that pushes for a shift in how we train doctors. Mm-hmm. I'd love to help change the system so there are ways that we've identified that can empower patients and not just make them greedy or demanding, but actually give them the tools to make better decisions. And I'd like that to become more a standard way that we do healthcare in this country. So those are my goals.
Awesome. That's not too much. You're young yet. You can do that. So Peter, thank you for joining us. This debate over American healthcare continues. Obviously, you're going to be a player in that. And thanks to the viewers for joining us today. This web stream will be available on Duke On Demand, which is ondemand.duke.edu. And when you go there, you'll find this and many other Office Hours broadcasts. Thank you for joining us today.
Produced by Duke University, online at duke.edu.